Now we go to the second session. It is a case discussion from Astromed, which will be moderated by Dr. Geeta Phillips, who is the head of the department. It will be presented by Dr. Vishnu Kurup. The title is Disease Dissemination, a Dilemma. We'll come to know what the dilemma is. Over to you, Dr. Geeta.
Good evening, everyone. So today's case discussion is going to be about a disease dissemination, which is a dilemma that most of us have faced in a clinical practice. So without wasting much time, I'll get to the case. So our patient was a 47-year-old male patient who came to us with symptoms of history of weight loss of 8 to 10 kg, so a period of 1.5 months, loss of appetite, high-grade fever with occasional on and off chills for a period of 1 month. The past history, he's a known case of type 2 diabetes mellitus for a period of 8 years, who's compliant on his medications. He has no history of any headache, any seizure, cough, shortness of breath, abdominal pain, or no prior surgical history. Coming to the personal history, he works at a fiber door manufacturing unit for a period of almost 6 to 7 years. He's a chronic smoker for more than 30 years, a 2-pack a day guy, and stopped since 3 months before coming to our hospital. Coming to the examination part, at the time of arrival, he was conscious, oriented, having significant temperature, a thin-built individual, having a dark complexion of skin. His sugar was normal and his vitals were within normal limits. So coming to the systemic examination, on his auscultatory findings, we got bilateral bronchi and fine crepitations predominantly heard over the infrascapular area, and the other system examinations were normal. So based on the history of presenting complaints in clinical examination and his personal history, we came with 3 initial set of differential diagnoses. The top of the line being a tuberculosis, a second one being a malignancy, and a third one being a hypersensitivity pneumonitis. So after this, we investigated with the routine labs. So the routine labs, the CBC showed mild leukocytosis with normal HPM platelet. He had mild hyponatremia with mild hyperkalemia. His renal functions and his inflammatory markers are normal. His peripheral smear showed neutrophilic leukocytosis with ANC predomination. His viral serology was non-reactive and his serum cortisol was low. Yes, sir. That's one of the differentials. Yes. Yes, we'll come to that. So then coming to radiologic investigations, the chest X-ray. Actually, this patient already had a chest X-ray when he came to a hospital. So we reviewed the outside chest X-ray first. That showed a faint reticulonodular infiltrates distributed uniformly throughout the lung fields. So in our hospital, we went ahead and did a HRCT thorax. So this is the HRCT thorax of a patient. It shows multiple small nodules, approximately size of 1 to 4 millimeter, scattered through, uniformly distributed throughout the lung fields with interstitial septal thickening also. So based on the radiological findings, we had consulted pulmonology. A bronchoscopy with BAL was done. So in bronchoscopy, the BAL culture, the cytology, the fungal culture, and the tuberculosis diagnostic panel, which includes the CBNAT as well as AFP, all were negative. And the blood culture was also sterile. We had sent 2 sets, both of them were sterile. So our X-ray had these findings, BAL bronchoscopy didn't show any particular conclusive fact. So we went ahead and did a whole body PET-CT because the patient also had persisting fever. So whole body PET-CT, the abdominal cut shows increase of FTG avid uptake in the bilateral adrenal soft tissue masses, and which is noted by the arrow mark over there. This is a FDG of the brain, which showed a tiny nodal enhancing lesion involving the left frontal lobe, which has a perilesional edema also. And since the adrenal part was the most accessible part, we went ahead and did an adrenal biopsy. So after the PET-CT, we came with a slightly modified version of differential diagnosis. So the first one was a neurocystic sarcosis based on the brain imaging we saw. A second one was a disseminated form of a tuberculosis. And the third one was a disseminated malignancy. So in the meantime, we got the adrenal biopsy that showed a necrotizing granulomatous inflammation, and the TB diagnostic panel from the adrenal biopsy showed a mycobacterium tuberculosis, With, yes, as you said, sir, adrenal insufficiency was there because of the hyponatremia and the cortisol low. So final diagnosis was a miliary tuberculosis. Is negative, sir. So after this, we had consulted infectious disease department in our hospital, and he was started on ATT treatment according to protocol. Ophthalmology consultation also sought, and fundoscopy was done, and choroid tubercles were confirmed. Endocrine consultation was sought for adrenal insufficiency, and he was treated symptomatically for that. So coming to a bit of what miliary tuberculosis actually is. So it's actually a clinical disease referring to the hematogenous spread of Mycobacterium tuberculosis. It is characterized by presence of small, firm and white nodules resembling millet seeds. That is why the name. It can either present as a progressive primary infection or a reactivation of a latent focus of a subsequent spread. So you can have two formats of signs and symptoms, an acute format as well as subacute or a chronic format. If in the case of an acute presentation, it will be a fulminant disease. It can either present in the form of a multi-organ dysfunction or an acute respiratory distress syndrome. If in the case of a subacute or chronic format, we'll have a pyrexia unknown origin, a failure to thrive, or an organ dysfunction like a patient had over here. The common sites of involvement are the lungs, the lymphatic system, the bones and joint, the liver, the CNS, and the adrenal glands. In our patient, are lung involvement, the CNS, as well as the adrenal involvement. Diagnosis always the clinical approach based on a thorough good history and a good clinical examination, which is often backed up by a histopathological finding, which indicates a presence of a granulomatous inflammation. The treatment is obviously the same as that of a pulmonary TB using traditional multi-drug regime. Sometimes in certain cases it requires a longer duration of treatment in case of immunocompromised host, a patient with a large organism burden, a slow clinical response, of in case a CNS involvement. And the patients in case have subsequent other comorbidities, adjunctive therapy is there. You can corticosteroids and supportive management with nutritional correction as well as management of the underlying diseases. So this is a follow-up of the patient. We had taken, this is on the left-hand side, you can see the initial CT scan we saw initially with the nodular lesion and the perilesional edema. And this is a CT we took after 6 weeks, which shows even though there's persisting nodular lesion, there is significant reduction in the perilesional edema. And the patient has now got his weight increase and is doing well now. Thank you.
Thank you, Vishnu, for presenting this case. And the main thing we wanted to present it was miliary tuberculosis. Diagnosis was very easy. Not now, earlier on. Why was it easy? The X-rays were always classical. There was typical, we don't have that X-ray. There's typical miliary modeling in the X-ray. So when I was a trainee, if you see that X-ray, that was enough to make a diagnosis of tuberculosis. And in miliary tuberculosis, it is not a must that we must detect mycobacteria. So even without, even with a negative one and a typical X-ray, we could make a diagnosis of miliary tuberculosis. But a paradigm shift has come along with newer technologies. And if you make a diagnosis of miliary cox without doing any of these things, you are in for a medical legal case. But this turned out to be interesting. The lung, of course, was there. And then we thought, the first day itself, we thought it was miliary cox. But then when we looked up, there is a whole lot of differential diagnosis, like you said. And this man was working in a fiber unit. So in lung diseases from asbestos and things like that could be also considered. And it is because of the newer imaging technologies, we could pick up the adrenal gland problem. In the ultrasound, it was not there. It was the PET CT which detected it. And then the brain. We had no clinical symptoms at that moment to suggest that there was a brain involvement. So another thing we realized is the word miliary tuberculosis. That also is no longer used much. We use the term disseminated tuberculosis. So a lot of change has come. And I suppose that is why we have CMEs and discussions to realize what is the change. So we want to know the opinion of the audience also. Thank you.
Very important finding. You may not get in asbestosis or any of the pneumoconias.
But he was a smoker. chronic
smoker.
smoker for 30 years. So that could have easily
The
been.
classical description about miliary tuberculosis is as if sand is
See the miliary.
But whenever you have a patient with hyperpigmentation, hypotension, and hyponatremia and eosinophilia, you have to think of
You have to
adrenal, either malignancy or tuberculosis in India. So that was a better track to go.
It was actually very interesting because we had to pick up all the findings, and it was the adrenal which showed the granuloma, and the adrenal showed the AFB, that biopsy of the adrenal gland. TB
Quite similar picture is seen in newborns, congenital adrenal hypoplasia. Quite similar picture, hyponatremia, hypotension, and pigmentation. Common.
And the next week we had a similar patient. She had no other finding except for the fever. And her X-ray was normal. But then we did a bone marrow, and the bone marrow had granulomas. And the granulomas were positive for AFB. And a little difficult convincing patients when they don't have a lung involvement as such, and it is in the marrow. And people think of tuberculosis as a stigma. They would rather have a malignancy than a tuberculosis.
We had some 30 years back, the octogenarian great physician, Joseph Kurian in Lisi. A case of fever, PUO, workup was done everywhere. And he had a habit of doing per-rectal examination in all PUOs, Bombay training. And he did that, and the prostate was enlarged, aspirated, AFB was seen. Such thrilling cases at that time.
And at the end of your presentation, you put NCC above TB. How common is adrenal insufficiency in cystic circus? It's common. I don't know. എനിക്ക് അറിയത്തില്ല അതുകൊണ്ട് ഞാൻ
ചോദിച്ചത്. In disseminated tuberculosis you can.
In cystic circus, NCC. That's why this patient had adrenal insufficiency, right?
Yeah.
Okay.
That's why we said it's a disseminated disease. And that's why pulmonary, extrapulmonary. Now pulmonary will be the lung only. Extrapulmonary can be one organ alone. But when it is disseminated, we had it even in the brain.
Yeah, exactly.
Now
that's
you can ask, how do we know the brain was part of the tuberculosis? Well, we had to take a risk on that. We could not go ahead and do a biopsy on the brain at that moment. So we assumed that, and then with the follow-up, we realized that he was responding.
Thank you.
Any more suggestions? Pardon?
If the adrenals were not enlarged, the PET scan, whether lung biopsy would be helpful in this case?
I think if the adrenals didn't show anything, what I would have done is, I would have thought about the miliary mottling. And we had the CT also, which shows classical miliary mottling. I would have started him on ATT, waited for at least 3 to 4 weeks to see whether he was responding, and then gone for further investigations. Of course, we would call that empirical treatment. And in India, I think one of the first diagnoses has to be tuberculosis. But of course, there is a risk. So Manto will be negative in these people because they are immunocompromised. Even AFP will be negative. We are fortunate to pick up an AFP.
The fluorocortisone is given in such cases.
Pardon?
Fluorocortisone in this adrenal insufficiency. These cases is mentioned, corticosteroids were given.
Yes, fluorocortisone is one. Just wait with that.
The paradigm shift in the management of a case, of course, your clinical, but then each step is different. So when you look back, perhaps you could have done this. Perhaps you could have done that. And even the treatment of tuberculosis there is a paradigm shift now. Like I think we learned category 1, 2, 3, and 4, but now there is only one way to treat it, and that is to start on 4 drugs. And it has become a notifiable disease. Otherwise, we have to notify the government that you have a patient with tuberculosis, and they would rather treat the patient. Otherwise, we will be punished if we don't inform them. So every hospital, I understand, has a system where you have to report it. Anything more? I think Karthik gave us only a little bit of time, so Vishnu had prepared this earlier on, so we didn't want to disappoint Karthik, that's why we. Thank you.